Prostate brachytherapy is changing. A new technique offers all the benefits of a one-stage treatment, but with none of its compromises. 4D brachytherapy. The team behind it are consultant urologist Professor Stephen Langley and consultant oncologist Dr. Robert Lang of the St. Luke's Cancer Centre. Together, they've been working at the forefront of prostate brachytherapy for over 10 years.
4D brachytherapy is a one-stage, real-time brachytherapy implant technique using a combination of stranded seeds around the outside and loose seeds in the centre. The fourth dimension is time, and to do that normally would take several hours in most techniques.
It encompasses some of the aspects of a two-stage technique and a one-stage technique, but combines them in a way that really does this in a quick time.
4D brachytherapy has allowed us to avoid the pre-planning scan. So it allows us to undertake the procedure as quick as if we were doing a two-stage technique, but we can undertake both the planning scan, the planning and the implant, all within approximately 45 minutes.
Having trained in America and performed the popular two-stage Seattle method for many years, the team was looking for a way to improve the technique and outcome for patients.
It required two substantial visits to the hospital. It required 2 anaesthetics. And whilst we could get a very good coverage around the prostate gland, sometimes we were covering a larger area than we wanted. And that could have an adverse effect in terms of erectile dysfunction and other urinary symptoms.
The concept of a one-stage treatment was attractive, but the length of time involved was a major issue.
The patient would be under anaesthetic, would have a planning scan, and then all the seeds would be cut in their strands, loaded into their needles, and then a plan developed as well.
Both the patient is anaesthetised for a prolonged period of time, and of course the theatre's in use.
Then the clinicians would start implanting the seeds, and the whole procedure would take between 2 and 3 hours. And we really felt that this wasn't advantageous to the patient.
In an afternoon's theatre list, only 2 patients could probably be treated in this way.
The challenge seemed clear. Find a way to accurately predict the number of seeds needed, prepare them in advance, and you can dramatically reduce the theatre time of a one-stage treatment. With this in mind, the team started looking into the relationship between the radiation dose and different sizes of prostate.
Having treated about 1,000 patients, we started to notice that there was a pattern in the number of stranded seeds we needed around the outside of the prostate and their position.
There were limited differences in the strand length. There were fairly close similarities to the amount of radiation that we had to order that allowed us to group different sizes of prostate together to get a solution that would allow us to have the right amount of radioactive material to perform an implant and give excellent dosimetry.
And that was really the key. Knowing that, we could then order those in advance so that when the patient was under an anaesthetic, we can miss out so many of the steps required normally, and it would allow us to undertake the implant in a far more time-efficient manner.
This breakthrough meant a nomogram could be produced, working from a simple ultrasound taken at clinic to calculate the right number of seeds. And it's this nomogram which is key to 4D brachytherapy.
The whole technique is possible because of the nomograms we've developed.
A lot of the pre-work has already been performed based on the nomogram that has told us how many seeds we're going to require. Those are pre-ordered, pre-loaded and ready to be implanted.
It allows us to use the simple measurements in outpatients to essentially deliver the first draft for that patient.
And it's a relatively quick process for the dose planning computer to assess exactly how many we're going to need and where those seeds need to be implanted as well.
This hybrid approach has shown both excellent levels of dosimetry and greatly improved side effect profiles for patients.
We can get a much better coverage of radiation around the prostate gland without risk of the seeds migrating away from the prostate. The loose seeds allow us to be very specific as to exactly where we implant the seeds within the gland. That minimises the side effects of urinary symptoms and also optimises the chances that the patient will retain their erectile function.
This film is designed to show existing brachytherapy centres how 4D works. Step by step, it outlines the way the treatment has evolved, giving tips on familiar techniques.
The seeds chains are being implanted in the longitudinal view,
as well as those less common.
I'm going to insert it into the MIC applicator. This cartridge has 15 loose seeds in.
Ideal if you are considering using 4D brachytherapy in your practice.
Date of birth 1347.
4D brachytherapy starts at a patient's first consultation with a standard urology workup to assess the prostate size and shape.
When I first see a patient and they've been diagnosed with prostate cancer, clearly I'm going to examine them, and part of that examination involves a quick transrectal ultrasound that I do in my clinic room whilst they're on the couch, lying on their left side.
To produce a seed calculation, the patient does not require a detailed planning scan. Instead, there are just 5 simple prostate measurements to obtain: the height, the width, length, and 2 parasagittal lengths. It's very important, however, not to compress or distort the prostate shape during this scan, as your measurements and subsequent seed order will be wrong.
It's from those measurements that we've been able to calculate how many stranded seeds that patient's going to require, and indeed how many loose seeds they're going to require when they come in for their 4D brachytherapy implant.
This is all done during a normal outpatient procedure when we'd be seeing the patient for the first time. And the advantage is that we don't need to bring that patient back for a second scan, so the next time we would see that patient would be when they come in for their implant.
For the first time, 4D brachytherapy enables seed ordering to take place online. Using specially developed software, the 5 measurements taken at clinic are entered into the website, which, using the nomogram, automatically calculates the seed order.
The nomogram will help create an order telling us how many stranded seeds we're going to need for that patient and how long they need to be, and how many loose seeds we're going to need to implant into the prostate.
A simple ordering system, the nomogram draws on the data of over 1,800 implants and provides a seed order specially designed to match your patient's prostate.
Our starting position with the number of seeds that the nomogram has suggested normally allows us to be accurate to within 2 to 3 seeds. Sometimes we need 2 to 3 seeds less than we'd predicted, sometimes we need 2 to 3 more.
To allow for this variation, the software always recommends extra seeds, at least 15, so there will be enough in theatre whilst the patient is under anaesthetic. It's an order that the clinician can override or refine at any point.
The nomogram only provides an order. That order, when loaded up and a match to the patient's prostate, involves the planning computer, and it's from the planning computer that the whole procedure is performed. It's just that the order actually happens to be very accurate in the number of seeds required, but the order doesn't tell you where you need to implant those seeds.
The day of the 4D brachytherapy implant. The pre-ordered seeds will have arrived a few days before in a radioprotective envelope ready for the physics team to prepare. Loose seeds are delivered preloaded into MIC cartridges. The strand needles are also delivered preloaded with seeds, spaced 1 centimeter apart and pre-cut to the correct length.
Not only are the needles preloaded, but they are arranged in the order that we are going to implant during the theatre procedure.
Needing to be handled only briefly minimises any exposure to radiation for the physics team.
Our preparation time has been cut dramatically. Before, we had physicists cutting and loading seeds that took, from an afternoon, theatrelist would take a whole morning of 2 physicists and a technician, and that really has all gone.
To make the strand preparation even easier, an autoradiograph gives a clear visual blueprint of the loading pattern.
We cannot open the needles and see what's inside. So this is going to tell me exactly how many seeds are in there. Needle 1 tells me that it has 4 seeds on it. Needle number 2 has 4, and then from 4th to the 10th we have 5 seeds. We don't have to worry of cutting any strands or anything. They are already there. You know that they are with the right amount of seeds, and you are ready to go.
With no needle loading required, a simple calibration process carried out the morning of surgery ensures that all the seeds are at the correct activity level. To do this, 2 samples are supplied with every order, 1 RSRX strand and 1 MIC cartridge loaded with loose seeds. Both are designed for use in fixed geometry holders and to be checked in a well chamber with a set calibration factor, which in this case is iodine 125. With the seeds calibrated, they are ready for theatre. The patient is brought to theatre after a routine pre-op assessment. We're using standard brachytherapy equipment, a computer-linked stepping unit, a biplanar ultrasound, and a computer with dose planning software. The physicists have brought the seeds in. The nomogram order should already be uploaded onto the planning computer, ready for real-time planning.
We're just about to start this case. The patient's anaesthetized, they're lying symmetrically on the bed, the ultrasound probe is in the rectum, we've lined the whole case up and are ready to start the implant.
With everything lying correctly, a detailed intraoperative planning scan of the prostate is performed for the first time and saved to the dose planning computer.
It's this planning scan that one would have done previously prior to the brachytherapy implant. But then one always runs the risk that the prostate may change in size or position between then and now at the time of the implant. And so we know that the prostate isn't going to change its shape whilst we've got him here to do the procedure itself.
Each time that Stephen outlines this on the ultrasound, I'll just take that, the planning computer is picking this up and registering it in the same way so that it can build up a 3D picture when we come to do the dosimetry at the end.
We can adapt to any particular shape of the prostate rather than trying to have to reposition the patient in exactly the same position that their planning scan was if one's undertaking a 2-stage technique. Now that's the final view we can see of the prostate in the transverse view. I'm going to take one more slice so we can record on the planning computer, and that's the study done.
With the slices now acquired in the transverse view, it is important that the virtual prostate closely conforms to the actual prostate shape. To do this, the contour of the prostate is checked in the longitudinal view to ensure a match and should be modified if necessary.
I can see the prostate, or the virtual prostate that we've developed on the planning computer, and we're just checking that it actually looks correct. If anything, I mean, if there's anything, I'll just get B5 and 10. Let's just. It's a little bit high, so I'm going to go back and alter that transverse image, and then we're going to just check that it looks okay. The prostate is going to swell and it's going to change shape, but if we get it as close to how it is now, it's going to be like this, more representative in a month or two's time as the seeds are still working.
It is now time to start creating the sleeve of radiation with the stranded seeds. Switching back to the transverse view, find the widest part of the prostate. Bring up the nomogram order and space the stranded needle positions equally around the perimeter of the prostate.
I'm, as it were, eyeballing and putting a centimetre gap between all the peripheral needles. And by doing this at this stage, it does mean that we can be sure that a good plan is achievable with the number of needles that the Nomograms given us.
Based on the dose feedback from the software and clinical judgment, there is always scope to adjust the number of needles as is felt appropriate to the case.
There is an option to remove a needle or two, but that seems to be something that we only rarely need to do. The nomogram is usually very accurate, more often enough that we'd want to either use the same amount or a few less as it happens. And I can see just looking at here that the dosimetry I'm getting here is excellent at the moment, so I know that the number of needles and seeds that the nomogram's given us is going to be correct for this case.
With the position of the stranded needles determined, they are transferred onto the ultrasound. This gives the operator inserting the needles a visual guide to where they need to be placed.
So the first thing I'm going to do is just put the local anaesthetic in.
The strand needles are in theatre on their tray, numbered and ready to be inserted. Using the ultrasound markers, the operator can then start inserting the anterior needles.
So at this stage we're not inserting the seeds, we're just inserting the needles into the correct transverse plane, the correct XY plane. I've placed the ultrasound so it's in the middle of the prostate gland, and that allows me to ensure that the needles are lying around the periphery of the prostate. The first needle I insert, I'm obviously looking at a coordinate to get an approximate indication as to where it's to go. And then the subsequent needles are very much in relation to that first scout needle, either two up, one across, or one down, one outside. And it's more intuitive, and one's implanting the needles where the prostate is, as opposed to just sticking rigidly to a grid or a coordinate, which is sometimes where the prostate isn't.
A key aspect of the 4D brachytherapy approach is that it allows both operators to maximize their theatre time. Tasks that were traditionally carried out one after the other can now be performed simultaneously.
Whilst the operator who's putting the needles or the radioactive sources into the patient, there are jobs that the operator who's using the planning computer can be getting on and doing. It gives me an opportunity just to outline the urethra and the rectum on each of these slices, which of course is important because we need to know what dose these structures get at the time of the real-time part of the planning procedure.
Undoubtedly, the procedure requires two trained people to perform this. So whilst I may be inserting the seeds, my colleague who would be driving the dose planning computer would be already undertaking the real-time planning to optimize the next part of the procedure.
The position of the loose seeds can start to be optimized, and this means when we get to the end of the stage of the strands being inserted, the plan is more or less already done.
To maintain accurate dose predictions, the actual XY position of each implanted needle is verified. The stranded seeds are now ready to be inserted.
I'm just going to line up the base of the prostate with the base plane as outlined on the ultrasound, and then Robert's going to bring the virtual image of the prostate so they all lie in sync. Okay, and that looks fine.
Needle number 1 has 4 seeds.
With each new needle, I'm just going to rotate the bevel of the needle, rotate the needle so that Robert can clearly focus on that needle, and we know that this is the needle in question.
4 seeds.
I'm going to advance it now to the base of the gland, right up towards the bladder. I'm going to move the little markers forward. The seeds are now sitting at the tip of the needle. I hold the plunger still and withdraw the outer sheath, and the seeds are again implanted. And the nomogram is going to allow that length is exactly right. The stranded seeds allow us to push the radiation dose out just a little bit further, particularly at the base and the apex of the prostate, without fear of the seeds migrating in the veins and moving to the lungs.
As well as generating a wide dose coverage, the 4D brachytherapy technique avoids issues with mobile prostate glands.
There is a considerable amount of motion of the prostate during an implant, some prostates by more than others, and that's why we feel it's very important to insert the seeds in the longitudinal view rather than some techniques where one was relying on the transverse image. It's very difficult to determine whether the needle is actually passing through the prostate or just pushing the prostate unless you're actually looking in that longitudinal view.
In contrast to techniques that deliver stranded seeds based on the retraction planes, 4D brachytherapy uses a different approach.
We've found that there can be a tendency to focus on these retraction planes rather than actually where the prostate is. So in 4D brachytherapy, we insert the needles to the base of the prostate as far up as we can, irrespective of whether that's a 5mm retraction plane, a 7mm or 7.5mm. And by doing that, we can really conform the implant to the shape of the patient's prostate rather than just relying on what can sometimes appear a rather complicated game of battleships to do the procedure.
This clear visual target, the base of the prostate for every strand, means the implant is both quicker and much more flexible to any minor variations in the size of the prostate gland. The 4D implant is not just about what's going on inside the prostate, however. The technique has evolved in such a way that the operators work together when implanting the seeds.
When it comes to actually implanting the radiation, it's very important that both operators come together. We've devised the technique that works well for us is that the person that is registering the seeds on the planning computer holds on to the cradle of the ultrasound and thus dictates the speed of the procedure. So we won't move on to the next needle, or can't move on to the next needle, until those radioactive sources have been registered onto the planning computer. And I'm swinging the cradle backwards and forwards and picking up the needle, as it were, tuning the ultrasound into that needle, and at the same time making sure that the computer is correctly identifying the right seed chain and marking it as implanted.
The procedure goes along at an orderly pace and we don't get out of sync ourselves.
Just occasionally, if you don't do it in this team-like way, then it can get out of hand. One's working quicker than the other and suddenly everything's disjointed.
Working as a team like this is crucial to the success at Guildford and comes from a belief that both operators' roles are interchangeable.
We have always decided that it was best that we would both be able to undertake all different parts of the procedure and be trained in different parts. So in some cases I'll put the seeds and he will drive the planning computer, and in the next case we will reverse those roles.
By working this way, each person's skill and understanding of the procedure develops, the team is more flexible, and the quality of the implants improved. With the anterior and lateral strands now implanted, the action is repeated for the last 4 posterior strands. Inserting these posterior needles can push the prostate anteriorly. It's good practice at this stage to realign the prostate in the transverse and longitudinal planes. Their close proximity to the rectum and the chance they block the view of other strands in the ultrasound makes these posterior needles better suited to a separate implant process.
We don't want to get them too close to the rectum and increase the risk of rectal toxicity. And so we like to do it at a separate sitting when we can be absolutely clear where the posterior region of the prostate is. It doesn't take any longer to do, but it just improves the accuracy of the implanted seeds. So we've now inserted all the seeds into the periphery of the prostate with our stranded implants. This has taken us 15 minutes to get to this stage.
The sleeve of radiation created by the stranded seeds is in place, and it's time for the final stage of the real-time planning phase.
When we come to the second part of the procedure, when we're using the loose seeds, We have a great deal of variability and choice as to where they go, how many we put in, and it's this, as it were, bespoke part of the radiation that can be optimised so that we're getting exactly the right dose to treat the prostate without overdosing these critical structures.
The team's clinical judgments in this planning stage are key. Using dose feedback from the planning computer, the nomogram loose seeds are positioned to build up the dose in the centre of the prostate.
This is our opportunity to really fine-tune the implant and the dosimetry we're going to get. All I've had to do is really move a couple of seeds and take a couple of seeds out, and we've got a very good dose distribution. And this is very quick. In fact, it's taken me only 5 minutes to do. So unlike a lot of other real-time procedures where it may be a 30 or 40-minute gap where this planning is being done, this really hasn't made a significant break in the procedure.
Virtually no time has been spent just planning this procedure because it's been evolving as I've been inserting the needles.
With the plan optimised, it can then be printed. And, as with the strands, the optimised needle positions are transferred to the ultrasound, ready for insertion to begin.
This is the mic applicator.
This is the final stage of the implant.
Remove the protective sheath.
Methods used to deliver loose seeds will vary from one centre to another. The 4D Brachytherapy team at Guildford used the mic applicator system. This system uses a combination of empty mic needles, cartridges preloaded with oncoseeds, and the applicator itself. With the needle positions already marked on the ultrasound, all the empty mic needles can be inserted.
Okay. Okay, so first one is in little. Do you want me to come? Yeah, I do.
In an identical process to the strand needles, the ultrasound probe sits mid-gland, and the mic needles are all initially inserted using the transverse view. Typically, the nomogram will suggest between 5 and 7 needles for implant.
Happy with that one? Yep. Okay. We're now going to cut back to the longitudinal view. Firstly, I'm going to line the prostate up with the base plane on the screen, and then the planning computer can then line up as well. So we are, again, all in alignment, all in sync. And that's looking just great.
With everything lying correctly, the final task of delivering the loose seeds can begin.
This cartridge has 15 loose seeds in. I'm going to insert it into the mic applicator. Robert's now going to focus on the first needle. I'm going to just advance the needle up as far as I can towards the base of the prostate.
Initially, the mic applicator is dipped in sterile water to stop it jamming with clotted blood.
Okay.
The loose seeds are implanted using the same two-person technique as the strands. Again, the clinician operating the planning computer controls the ultrasound, ensuring that the planted seeds are marked accurately.
The loose seeds within inside of the prostate allow us to have great flexibility exactly where we place those seeds in relation to the urethra, and particularly downstream at the apex of the prostate, so that we don't over-treat those nerves and run the risk of our patients developing erectile dysfunction.
Level 35.
Hang on, Amanda.
It's here that the mic applicator is most effective at getting the radiation dose into the prostate with these critical seeds.
Level 45.
Normally the stranded seeds are at 1 centimetre spacings, whereas a mic applicator allows us to have 2 seeds right together, and then a large gap, and then perhaps another 2 seeds, and then another gap. So it allows us great flexibility, and we need that flexibility because we may wish to place those seeds in any particular place to optimise the dose to the gland.
Level 10.
Well, the difficulty with a strand, its length is fixed, so you can get one end right, but actually sometimes the other end is going to be just out of position. So you normally can't put the seeds any higher into the prostate, or they'll be lying in the bladder. So what tends to happen, it tends to come out. Not only can I be very tight on getting the seeds right at the base of the prostate, but I can also get exactly the seeds at the apex of the prostate.
This will be particularly important when there is a very mobile gland to deal with. If there are slight movements, these can easily be followed to give a dose that conforms to its shape and contour.
Nearly done, team.
4 seeds, first of
It does mean that as we're inserting, particularly the loose seeds, if we see that the prostate has expanded and is a little bit longer than what it was at the beginning of the procedure, we're going to put some seeds in there and cover that gland.
We do really need to look at where the prostate is and how the prostate's moving. We actually make sure we treat the prostate gland rather than just blindly following a plan and hoping the prostate is where your coordinates say it is.
It's very important that we cover what we see, as it were. And it sounds simple, but it's an important lesson.
Finishing off the final few seeds, the implant is complete.
Okay, so that's all the seeds implanted into the prostate gland. This case has taken 42 minutes, as it happens, to perform. We're just going to finally check the dose planning computer and that the doses to the prostate are just as we had hoped.
The dose in this situation is excellent. I'm just, at this moment, just flicking through from 5mm cut to 5mm cut, just to make sure that our 145 isodose is fully covering the prostate, which it is. I can see that my D90 is ideal and that urethra and the rectum are getting very low doses, so we're pleased with all this and we're going to finish the procedure here.
In 4D brachytherapy, the expected doses are V100 above 95%, V150 between 55 and 65%, D90 between 155 and 185% Gray, higher than the prescribed maximum of 145 Gray, as it will reduce slightly by the time of the post-implant dosimetry CT scan. The U150 for the urethra should be below 7%, and the R100 for the rectum less than 1 cc. As with standard brachytherapy practice, a CT scan is performed post-implant for quality assurance. Once patients wake up in recovery, they go straight to be scanned before returning to their ward.
The great advantage we feel of doing this immediately afterwards, rather than waiting perhaps 6 weeks that many centres undertake, is that we get a very quick feedback as to the quality and the nature of the implant. And within a few days, we will have the dosimetric parameters, the outcome measures, the quality assurance for that man's implant.
This film has been a practical guide to 4D brachytherapy. Follow this simple structure and take advantage of the benefits on offer.
I know that when that patient gets off the bed that the implant's going to be of an excellent quality, whereas with the old technique perhaps you didn't get that feedback during the procedure.
A quick and accurate real-time technique.
If you have a boost, we can do in 20 minutes. We have done already in 20 minutes the whole treatment from the start to the end.
Improved quality of life for patients.
It's a shorter anaesthetic for the patient, so the patient recovers more quickly, but also we can provide a higher quality implant with a lower side effect profile for patients as well.
And the most efficient way to run a practice.
It's more time efficient for the clinician and for the hospital, and overall is more convenient for everyone involved.
For more information about how you can bring 4D brachytherapy to your practice, please visit www.4dbrachytherapy.com.